The devolution era has yielded significant results in this regard, increasing access for mothers and reducing morbidity and mobility for both the mother and the baby. With 89% of mothers currently delivering under skilled care in Kenya, as compared to 66% before devolution, that is before 2010. There has been a rapid decline in maternal and child mortality rates, and I would say that between 2014 and 2022, Kenya's under 5 mortality rate reduced from 52 deaths per 1,000 births to 41 deaths per 1,000 births, and the infant mortality rate from 39 to 32 during the same period per 1,000. For a doctor to stay in Wajir, they need to be remunerated in a way that it gives them motivation to stay there, while a doctor may not need any motivation to work in Roiro and Thika and on Gong Road in Nairobi. Difficulty with recruitment and retention is a big problem, because internal and external migration of health workers is at all-time high. The development of training programs for community health care workers could not have come at a better time in Kenya than now, when the country has just enacted 4 acts of parliament to achieve universal health coverage. These acts have introduced fundamental changes in the delivery of health services in Kenya, placing primary health care and community health promoters at the center of health delivery services. The healthcare workers has a big shortage. Currently, the Kenyan public sector has a health worker crisis with only 14 health workers per 10,000 Kenyans. That ratio is something that I think is not duplicated in Western countries, but I believe it's a common scene in almost all of Africa. 14 to 10,000. So even when we talk about exporting health workers, it is a paradox, because we are giving away the cream de la cream, while our people are being treated either by low cadre, I don't want to say quacks, but it is definitely a crisis, because we are supposed to be retaining the best while we export the surplus. We spend as African countries a lot of money in training our health workers, and we are giving them out for free to Western world. At the ignorance of assuming that they need jobs because they're jobless, yet our health facilities have a shortage. The reason I'm saying this is because you know very well that we do not have, especially in Kenya, and you've put it so well that this is handled by labor. The training is by Ministry of Health. But when you come to giving away the workers, they're given away by labor. We do not even bother to know how much it costed to train them in terms of government resources, which is taxpayers' money. You know how much it costs to train one nurse, how much it costs to train one clinical officer using taxpayers' money, because they don't study at home. But when you give them out to the Western world, you give them out for free. Nothing comes back from those countries to support the training in these institutions, so that we can keep on churning more of those health workers to be able to have no break or no gap in delivering both for us and even out there. The doctors have preference to work in the cities and urban areas vis-a-vis going to the villages, where we have less opportunity to have private practice and also have less workforce, and therefore may not be having very big opportunities to be able to venture into private sector. But the disease burden is usually highest in those rural areas. So there's a paradox. We complain that we do not have enough health workers in our facilities. It is true, I gave you a ratio of 14 to 10,000. Why is it that we have very many nurses who have been trained coming out of the nursing and medical colleges, yet we have shortage in our facilities? It is a question of affordability, it is a question of funding to health. While we are complaining we are having a brain drain of doctors and nurses who are going to Western world, we as a government are not able to afford to employ them, because we do not have the resources. Recently, I advertised for a position of 30 nurses in my county. I got application of 667. And those are not working in any other facility. Those, because we say in the application, ensure that you're jobless. Those are the ones you give. So you have very many nurses at home. Some of them have been there for 2 years, 3 years, and therefore, by the time we hire them, they also need refresher courses, Professor Kanyinga. So when you are tailoring this program, you should have a refresher course for those who stay at home for a longer time before they are taken for employment. Because it's there in Kenya. Whether they're going out of this country, whether they're coming to our facilities, they need refresher training. There is a big lacuna in the program in that while those doctors go on study leave, they continue drawing salaries from the county governments, who at that particular time have a gap because of the absence, and they need to hire other doctors to replace them while they're on study leave. That becomes a double burden for the counties. You pay doctors who are away, and at the same time you're supposed to hire those who are supposed to replace them with very meager resources from the counties. In that space, we are requesting that the national government should be able to, or the ministry, I say we have one government approach. The ministry, as much as they're doing the tuition or they're paying for the tuition, they should also be able to pay for the salaries for those doctors while they're away. That gives an opportunity for the counties to cover for the gap that they leave while they are on the study leave. I gave an example the other day, and I still do the same. I don't want to talk about other counties. I have 36 doctors in Tharaka Nithi County. Currently, 14 are on study leave. Therefore, it means I have on record 36, but physically, I only have 36 minus 14, and I am paying for their salaries. Can I afford to have other doctors to replace them? That's a question for another day, because your answer is as good as mine. But the specialization, the specialized health workers, like the postgraduate doctors, we have a big shortage in Africa. And that is why today in the Kenyan scenario, and I say this in public, we have, for example, have only 60 oncologists in Kenya with a population of almost 60 million. Why is it that we cannot emphasize on having those specialists in Kenya as much as we are focusing on the lower cadre? I have been looking for a radiologist for Tharaka Nithi for the last 3 months without any success, since my Cuban radiologist left. And we, as much as we are even offering very high salary, we have not been able to attract any, because my county is rural. So the issue of the urban doctors again is affecting us, because they would prefer to read the images from Nairobi while we are based in Tharaka Nithi. And that professionally will not yield a lot of results, because as much as you read the images, you also need to look at the patient to know whether it is true, and even the equipment that have been used to take those images. So there's a mismatch. We need also to focus on training on higher cadre doctors. We have to go above the budget declaration of spending 15% or 15% on health, and spend much more. In Kenya, counties are spending over 30%. However, it is 30% of what the counties get, because when we are sharing the national cake, what we call equitable share, our counties are getting 15% of what is available for the whole nation. So even if you spend 30% of that on supporting health, it is still a drop of water in the ocean. So to avoid this problem in the whole of Africa, we must deliberately spend or channel more resources to support health. And that is how we shall benefit our human resource as well.
We are saying we must produce fit for purpose. Don't just produce. Sometimes in our space of regulation, we find that, like I'll give an example just from medical school, CF is here. They are producing 1,000 doctors now. 5 years ago, they were producing 300. So we wonder if those 1,000 are able to fit in those internship centers, the training centers, and getting exactly what they require to come out. So those are the things we want to look around and see what they are doing. So production, we want to see fit for purpose production. Between the institution of training, we are training for 2 markets. We are training for our Kenyan market, we are training for the outside market. but we don't want to overtrain what cannot be absorbed. So let's train what we really do need.
But if we don't build an ecosystem in which the training and preparation and reskilling, upskilling of young Africans to be relevant to healthcare is connected to their work experience and to employment. If they're not work ready in that healthcare sector, we will not actually be scratching the surface of this.
We have under challenge in this country, we have under challenge in East Africa, where training of doctors, and with due respect to Dr. Serango and other doctors who are here, I think when we train doctors, a majority of them become urban doctors. Rarely do they go to the rural areas, and there is a challenge of telling them, please go and work in the rural areas. That becomes a problem. So we have got doctors trained, but then once you leave your rural area and go to a university, that's the end of you and the connection with the rural areas. And even when you are posted to work in the rural areas, every weekend you travel back to the city. I've seen it in Ghana, I've seen it in Nigeria, I've seen it in Cameroon. When people travel back, the village looks like you are touring the village, or you are touring the village, and you are comfortably seated in urban.